forms of the disease have in common a potentially progressive and characteristic optic neuropathy, and which is associated with the visual field loss as the damage progresses. And in this condition, intraocular pressure is usually the key modifying factor. If we'll try to define the glaucoma on a molecular level, then this has a diverse etiology which is linked by the presence of endothelial leukocyte adhesion molecule 1, ELM1, which indicates the activation of a stress response in the trabecular meshwork cells. Now, coming to the epidemiology, glaucoma is a very common disorder. It usually affects up to 2% of those over the age of 40 years globally, and up to 10% over the age of 80. And 50% may remain undiagnosed. As you know that glaucoma is usually an asymptomatic disorder, so it exhibits an iceberg phenomenon. So a number of the cases may remain undiagnosed. Now, in a population of European or African ethnic origin, primary open-angle glaucoma is the most common form. And on a worldwide basis, primary angle closure glaucoma constitutes up to half of the cases, which is particularly with particularly high prevalence in the individuals of Far Eastern descent. Now, when we'll talk about the classification of the glaucoma, glaucoma can be classified as congenital or acquired, and then subclassified into open angle and angle closure, depending upon the mechanism by which the aqueous outflow is impaired with respect to the anterior chamber angle configuration. And distinction between the primary and secondary glaucoma is also made. And as you know that when we say it's a primary glaucoma, it means it's idiopathic, or it has got no known cause. And when we say it's a secondary glaucoma, it means there's some recognizable ocular or non-ocular disorder that contributes to the elevation of the intraocular pressure. Now, glaucoma has always remained a challenge for a clinician, for an eye specialist. Its diagnosis is not easy always, especially in early stages. The reason being that 50% of the individuals with the glaucoma have normal intraocular pressure. And on the other hand, 2/3 of the people with the elevated IOP never develop glaucoma. And in spite of the recent advances in static perimetry, in recent advances in the methods of taking intraocular pressure, with the latest investigations like OCT, still it is not easy to detect glaucoma, especially at an early stage. And why it is important to detect glaucoma at an early stage? Because you know that the vision loss in glaucoma is irreversible. So the process of this vision loss should be halted with medical or surgical management at an early stage to prevent the permanent loss of the vision and for the prevention of the blindness. Now, coming to the presentation, how does a patient with glaucoma will present to you? As I have already discussed that usually the patients are asymptomatic. This is more common with the chronic glaucomas. When we talk about the acute glaucomas, like acute primary angle closure glaucoma, the patient may present to you with severe pain. But the most common presentation of the patients with glaucoma, especially the chronic glaucomas, is asymptomatic elevation of the intraocular pressure, and the patient usually does not have any visual symptoms. So not everyone with the high pressure has glaucoma, but in spite of that, the doctor should evaluate the patient with high pressures and should follow up on their future course, regardless of whether the evaluation reveals glaucoma. Now, when we talk about the IOP, no sharp boundary separates the elevated from the normal pressure, and usually as an arbitrary point at which to become suspicious, the traditional definition of the elevated intraocular pressure is the pressure of 22 millimeters of mercury or greater, or we say it's 2 standard deviations above the mean. Now, when we talk about the clinical evaluation of a glaucoma suspect, now we have to take a thorough history and we have to do a thorough eye examination. Now, in relation to history taking, two important historical information are to be obtained. Number one is the history that is related to diagnosis and the history that is related to management decisions. Now, in diagnostic point of view, we have to inquire about the use of the drugs, especially the corticosteroids. Now, steroids, whether taken orally or topically, for example, application to the skin of face, this may result in elevation of intraocular pressure. Then you have to take a history regarding any trauma or injury, and it might be years back. So this may result in the elevation of intraocular pressure. Then coming to the management points, there are two important things. One is the family history, another is the medical history that you have to take for the management of glaucoma patient. Now, glaucoma is often hereditary, and if any of the patient's relatives have glaucoma, then you have to determine the severity of their disease. A family history of severe glaucoma increases the suspicion that a patient may have a similarly severe course. In relation to the medical history, you have to ask about if the patient is allergic to sulfur drugs, or you have to inquire about any renal disease. So those patients who are allergic to sulfur drugs or who have any renal disease are relatively poor candidates for the carbonic anhydrase inhibitors. Then you also have to inquire about congestive heart failure and asthmatic respiratory problems, which may worsen during the treatment by using beta blockers. Then you have to take a history regarding any vasospastic disease like migraine or Raynaud's phenomenon. Then you have to inquire about any low blood pressure or hypotension, and this may increase the patient's susceptibility to pressure-induced damage. Once you have taken a proper history, we'll examine the patient's eye. And there are four important components of diagnosis and management of glaucoma. The first one is the measurement of intraocular pressure. The technique is termed as tonometry. The second is visual field analysis or perimetry. The third is optic nerve head evaluation, or we call it fundoscopy. And the fourth is evaluation of the anterior chamber angle, which is termed as gonioscopy. Now, these are the four most important diagnostic tools or four main components on the basis of which you have to diagnose the glaucoma. We'll discuss these four diagnostic techniques briefly. Let's talk about the first technique, that is tonometry, or the measurement of intraocular pressure. We can classify the tonometers into contact and non-contact tonometers, or we can classify them into indentation and applanation tonometers. Now, indentation tonometers include the Short's tonometer, which takes the intraocular pressure by indenting the cornea, whereas the applanation means flattening of a surface. So the applanation tonometers, they take the IOP by flattening the surface of the cornea. Now, in contact tonometers, we have the Goldman contact tonometer, which is an applanation type of tonometer. Then we have the Perkins contact tonometer, which is also an applanation type of the tonometer, and it is portable and used in supine position. Especially it is used in OT settings. Then we have the Shorts contact tonometer, which is an indentation type of tonometer. And then we have the tonopen. This tonopen is also a contact applanation tonometer, and it is a portable type of the tonometer. Then when we talk about the non-contact tonometers, we have air puff applanation tonometer and pulse air, which is a portable non-contact applanation tonometer. Now, when we are using contact tonometer, we have to use the topical anesthesia for touching the cornea. And with the contact tonometers, there is also a risk of cross-infection. Among these tonometers, the Goldman's applanation tonometer is considered as the most accurate and gold standard for measurement of intraocular pressure clinically. Now we'll talk about the next technique, that is assessment of anterior chamber angle, that is termed as gonioscopy. Now for this technique we should understand the anatomy of the anterior chamber angle. Now there are four important components that we need to identify while performing gonioscopy, and these are from anterior to posterior, the Schwalbe's line, then which is the peripheral termination of the Descemet's membrane. Then we have the trabecular meshwork or trabeculum. Then the third is scleral spur, and the most posterior is the ciliary body. We can classify the glaucoma into open angle glaucoma or angle closure glaucoma based on the identification of these structures. So there are so many grading methods that are available for measurement of anterior chamber angle width. The most widely used is Schaeffer's grading method for the measurement of the anterior chamber angle width. Now in this method we can grade the angle from grade 0 to grade 4. Now grade 0 means that there is iridocorneal contact. When we say it's grade 1, it means that we can only see the Schwalbe's line. If we say it's grade 2, it means that we can see the trabecular meshwork. And if we say it's grade 3, it means the scleral spur is visible. And if we say it's grade 4, it means all the four structures are visible and we can easily see the ciliary body. When it's grade 0, 1 or 2, then it's narrow angle glaucoma, and if it's grade 3 or 4, it's open angle glaucoma. Gonioscopy is done with the help of the gonio lenses, and the commonly used gonio lenses include the Goldman's gonio lens, that can be a single mirror or a triple mirror, and a Zeiss 4-mirror gonio lens. Now when we see that if a patient is having grade 0 angle, which means that there is iridocorneal contact, then we need to decide that whether this contact is just a positional closure or it is a synachial closure. Means that the anterior synechy has been formed between the peripheral iris and the posterior surface of the cornea. Now how we can differentiate between these two types of the angle closure? This is by means of a technique which is called as indentation or compression gonioscopy. This technique is performed by means of a Zeiss lens. Now what happens that first we have to examine the anterior chamber angle without applying any pressure. We apply a little force onto the eye with the help of a Zeiss lens. And what happens that when we apply pressure onto the eye, the aqueous is pushed into the anterior chamber angle, and this forces the anterior chamber angle to open. So if it is a positional closure, the angle will open, And if it will be a synechial closure, either it will not open or it will be partly opened and the synechia will be visible. The third technique is fundoscopy, or assessment of the optic nerve head. Now, optic nerve head is also termed as optic disc. Now, as we all know that there is a small cup in the center of the optic disc, and which is a normal physiological cup. But in glaucoma, what happens that as the glaucoma progresses, the optic nerve fibers start to undergo apoptosis, or they start to die, and this results in thinning of the nerve fiber layer, resulting in the enlargement of the physiological cup. Now when it enlarges, it no more remains physiological. Now you have to look for the two important things while examining the optic disc in a glaucoma patient. One is the pellar and other is the cupping. Now, pellar is the maximum area of color contrast, and whereas cupping is the banding of the small blood vessels while crossing the disc. Sometimes the cupping and the pellar may correspond, and sometimes the cupping is greater than pellar. So it is usually the cupping or the CD ratio, cup disc ratio, that is measured for the assessment of glaucoma. Usually it occupies the three parts of the disc, which is termed as CD point 3. But as the glaucoma progresses, it may enlarge in a form of a notch, or it may enlarge concentrically. Now we have to examine the fundus with the help of either the direct ophthalmoscope or the indirect ophthalmoscope. These are the two techniques for the assessment of the fundus. While examining the optic nerve head, you have to assess the color and the width of the neural rim, the size of the cup and the contour of the cup, and you have to assess the presence or absence of any notches and hemorrhages, and express to the nearest 1/10 the ratio of the cup, not the pellar. So the small disc have the small cups with a median CD ratio of about 0.3, whereas large disc have the large cups with a median CD ratio of about 0.5. And you should remember that 2% of the population have a CD ratio that is greater than 7. Now, the findings that strongly suggest the pressure-related damage includes the asymmetry between two cups of 0.2 or greater in either axis, vertical or horizontal, in the disc of equal size, or the vertical elongation of the cup such that the vertical cup measurement is greater than horizontal, or there is a thinner rim of tissue in vertical pole of the disc than elsewhere, or there is a distinct local notching of the nerve tissue, or there is a disc margin hemorrhage. After examining the disc, evaluate the fundus for evidence of any other disease, and in particular you have to look for an old branch retinal vessel occlusions or other retinal lesions that might correspond with any visual field defect. The optic nerves should be photographed for the sake of future comparison. The optic nerves should be photographed for the sake of future comparison. Now we'll talk about the technique for the assessment of the visual fields, which is termed as perimetry. Now, no eye examination is complete without the assessment of the visual field. And for the routine eye examination, the confrontation field test suffices. But for the patients with elevated IOP, we should have the formal visual fields done. And for the glaucoma patient, the recommended technique for the visual field assessment is automated static threshold perimetry. This is the printout of Humphrey field test shown here. Now you can appreciate that on the top there is a gray scale which shows the inferior hemifield defect, and there is also a depressed area at the periphery of the superior field. Then in the middle we have the total deviation charts, which are adjusted for the normative data and that are age adjusted, and inferiorly we have the pattern deviation charts. Now you know that you may get a defect in a visual field due to other neurological diseases as well. So there are certain characteristics which differentiate a glaucomatous visual field defect from the rest of the causes. The characteristics include that these glaucomatous field defects will be asymmetrical across the horizontal midline in early and moderate cases. They might be located in the mid-periphery. They usually start from the mid-periphery in the early and the moderate cases. And they are clustered in neighboring test points. They are reproducible on at least 2 occasions. They are not explained by any other disease, and they are considered a valid representation of the subject's functional status. So they are based on the performance indices such as false positive rate. These slides show that how the glaucomatous visual field defects progress. We can classify the glaucomatous visual field defects into early, moderate, and advanced. Now in early stages, usually you can have a small arcuate scotomas that tend to elongate circumferentially, or we can have an isolated paracentral scotomas or the Roney's nasal step. This slide shows you that how the glaucomatous visual field defect progresses, and they show you the formation of the arcuate defects, the enlargement of the nasal step, and the development of a temporal wedge. This slide shows you the advanced visual field defects. It shows the development of a ring scotoma and a residual central island, and the other one shows you the peripheral and the central spread and the residual temporal island. Now let's talk about the glaucoma management. Now we have the 3 options. The glaucoma can be treated with the help of drugs, or with the help of lasers, or in advanced or resistant cases we may need a surgical intervention. These are the 5 groups of the drugs that are used to treat glaucoma. They include beta blockers, sympathomimetics, or we call them alpha-2 agonist, myotics, which include pilocarpine and carbachol, very potent anti-glaucoma drugs, but now used less commonly due to the side effects. Then we have the prostaglandin analogs, which are considered as the first-line anti-glaucoma drugs. Then we have the carbonic anhydrase inhibitors, which can be used in topical and systemic forms. Now laser treatment, laser trabeculoplasty is used in case of the failed medical therapy, or it may be used as a primary therapy in a non-compliant patient. Laser therapy may be used alone, or it may be used as an adjunct to the medical therapy. And it is believed that the laser procedure causes the increased outflow facility by the mechanisms which include mechanical tightening of the trabecular meshwork to open the adjacent untreated trabecular spaces, and or by inducing the cell division and migration of the macrophages to clear the trabecular meshwork of debris. But this laser procedure is ineffective in pediatric glaucomas and in most secondary glaucomas, with the exception of pigmentary and pseudoexfoliation glaucoma. Now, the third option is surgical intervention, and which usually includes the trabeculectomy, a filtration surgery. Now, the indications for the trabeculectomy includes failed medical therapy and laser trabeculoplasty, or the lack of suitability for the laser trabeculoplasty, like poor patient cooperation or inability to adequately visualize the trabeculum. Then this trabeculectomy may be used as a primary therapy in advanced cases which are diagnosed in later stages of the disease. Now with this we conclude the lecture, and I hope that this is a good refresher for you, and for any queries you can send me your questions